There have been several approvals in the last 2 years. Among them, the drugs targeting ivosidenib, targeting IDH1 and IDH2. Those two drugs were approved a little bit earlier, and we've already started to see evidence to suggest their substantial clinical utility. In the relapsed refractory patients, they've been established, they're now approved. And at this meeting, Dr. Stein is going to present some data really showing very intriguing and very exciting combinatorial activity in combination with 7 and 3. So I think those agents are likely to come a little bit more upfront in our AML therapeutics, which really pushes us to get mutational profiles back quickly. Other agents that have now been approved include targeted agents targeting FLT3. So very recently we have approval of gilteritinib in the context of relapsed refractory disease. That data has actually not even been presented other than in abstract form, and so we don't have the final publication, but that is very exciting. The other agents that have newly been approved include these non-targeted drugs, things like the combination of azacitidine or decitabine or low-dose cytarabine with the BCL2 inhibitor venetoclax. Again, not a combination that is really molecularly targeted. In fact, it seems to have activity in a variety of different AML subgroups, including FLT3 mutant patients, IDH mutant patients, where it seems to be particularly active, and also in those patients with poor risk features such as P53. So I think that this novel therapy, which seems to have a really remarkable activity in patients with historically what was deemed unfit disease, people who are historically deemed unfit for standard therapies, that approval is extraordinarily exciting. The drug Glastigib was also approved recently in combination with low-dose cytarabine. The responses to that combination were a little bit less impressive, but nonetheless it seems real and durable. So those approvals are all very, very exciting. And I think in the AML field, we're really privileged to have approval of so many new drugs. Also, we have the non-targeted therapies of Vyxeos, again, also packaging, if you will, of 7+3, which seems to have substantial activity, particularly in those patients with poor risk cytogenetics or secondary type disease who are then going to go on to allogeneic transplant, where we tend to use that kind of combination as an alternative to intensive induction regimens.